Presenting to you Dr. Senthil Kumaran from United Kingdom. Dr. Senthil Kumaran is a consultant anesthetist at Northampton General Hospital, United Kingdom. He is a fellow of the Royal College of Anesthetists. He has held a honorary senior lecturer in medical education from Leicester University. His practice includes cardiopulmonary exercise testing for optimizing perioperative care and risk reduction. He's also a proponent of simulation, and he has done several workshops in India on simulation. I have great pleasure in presenting Dr. Senthil Kumaran from Northampton to us.
Hello and good morning. I'm Dr. Senthil Kumaran, consultant anesthetist from Northampton in UK. In this talk, I will focus on how we can encourage our patients to actively participate in their cancer treatment using rehabilitation programs and improve the chances of survival and better quality of life in the long run. Cancer diagnosis, no doubt, is a very distressing time. After an initial period of fear, anxiety, and anger, patients are very keen to know about what treatment options are available and how likely are they to be able to survive this episode. In our experience in Northampton, an air of positivity often engulfs the patient the moment we offer them a prehabilitation program. It gives them an opportunity to actively participate in their treatment and look forward to a better outcome and survival. The idea of prehabilitation was conceived when preoperative neoadjuvant chemotherapy was introduced for esophageal cancer resection. Such patients rapidly lost their functional fitness and needed a long time to recover from chemotherapy, delaying surgery. Prehabilitation was introduced in this group of patients to accelerate their early return to pre-morbid chemotherapy state. During this lecture, I will talk about the rationale behind prehabilitation programs. What is the level of evidence to support this modality of treatment? What are the components of this program and how best we can deliver this? I'll also make a comment on what the future holds for this kind of intervention. The definition of prehabilitation can be very confusing when we start looking at literature. It is important to note that whatever definition is used, it has one common theme. That is, it is a preemptive preparation for patients using physical and psychological tools in order to reduce the risk of and major intervention and enhance the recovery. Exercise in cancer. A study published in 2010 by Public Health Australia looked at attributable causes for cancer. No doubt, tobacco was at the highest in this table. Having said that, what was also surprising is that insufficient physical activity was an independent risk factor according to this study. In a similar vein, a large meta-analysis published in 2016 in Lancet looking at over 1 million patients found that patients who had an active lifestyle and very little sitting time when compared to sedentary lifestyles had a better chance of survival. They have found that patients who are sitting and without any activity for a longer period of time, irrespective of their functional fitness, had a higher chance of mortality. There is some good news about cancer treatments. The mortality is continuing to decline for both male and female population. The bad news is, though, that the incidence is likely to double in the next decade. What is more worrying in this situation is that those patients who are surviving for a longer period of time seem to have a poor quality of life and increased frailty. This has a healthcare burden in terms of cost, and it's a vicious cycle. Prehabilitation hopefully will have some effect in reversing this phenomena. Whenever a cancer diagnosis is made, a number of cancer treatments are considered. For early cancer, surgery still remains to be the mainstay, offering curative outcomes. Any form of cancer, irrespective of what is being chosen for a patient, can be debilitating in terms of treatment. Debilitating treatments can interrupt because of ill health. Treatment interruptions leads to poor outcome. Prehabilitation reduces this treatment interruption by increasing their functional fitness. As an example, let us look at chemotherapy's effect on muscle mass. All cancer patients exhibit a variable degree of inflammation, leading to loss of muscle mass and strength. They also have lipolysis and raised inflammatory markers. Patients who undergo chemotherapy in these circumstances are likely to suffer significant loss of muscle mass, and this is clearly demonstrated in the CT scan. On to your left is a CT scan marked in red, demonstrating the quantity of muscle within an abdominal cavity and a significant depletion following chemotherapy. In this diagram illustrates the concepts of prehabilitation and the theoretical possibility of improvement in outcomes. Any patient who is recruited into cancer treatment, when offered a prehabilitation, are likely to mount a better response to the surgical or chemotherapy insults and recover back to previous functional state as soon as possible. This can also improve frailty in some sort of patients, but the evidence is poor in that aspect. What are the key components of a prehabilitation program? Fundamentally, the first on the list is exercise prescription and medical optimization. This is followed by nutritional evaluation and monitoring of dietary intake and calorie regulation. Some help is offered to patients in order to modify their lifestyle and stop smoking and reduce alcohol intake. We all know that even a 4-week cessation of smoking has a very positive effect on wound healing and reduce complications, especially pulmonary complications. All of these three aspects are not easy to achieve for patients within a short period of time, and motivational support followed by stress management and relaxation strategies helps them to improve the compliance to the above three modalities. So why is there a positive effect for exercise on outcomes? Exercise, we all know, increases our cardiac output. It increases the tissue's ability to extract oxygen and utilize it efficiently. It increases muscle mass, and we also have seen that a notable increase in mitochondrial density, which has an impact on cell function. The postulation is that all these effects increase the cardiopulmonary reserve and decrease complication rate and early return to pre-morbid functional status. We have also demonstrated in studies that mortality is also decreased in this group of patients. To illustrate the point, I'm extracting 2 studies from literature to show you that any patient who is able to preserve muscle mass are able to survive for a longer period of time. In the first example is pancreatic cancer resection. Patients who were followed up for over a 5-year period, and patients who had better muscle mass and preservation had a better survival. Similarly, in the case of liver resection, for a follow-up of 48 months, patients who exhibited sarcopenia were less likely to survive when compared to patients who had better muscle mass. So what is the evidence available for prehabilitation? There are a number of randomized controlled trials which show positive effect, but they are small in numbers, and there are also a lot of tumor-specific trials which show positive effect. Of recent, systematic reviews and meta-analysis have published which show strong evidence towards prehabilitation. There is some problem with comparing these studies because there is variation in the type of cancer which is studied, the regimes used, and the measurement tools used. We can say that there is enough evidence to support prehabilitation, especially for the exercise-based regimes. Macmillan Cancer Support in UK have also come to the same conclusion that there is a good deal of evidence to incorporate physical activity as a tool to improving patient outcomes. So in a real life example, I will talk you through what was the impact of this kind of approach in the clinical setting. Imperial College in London have a program called Prepare, which incorporates components related to prehabilitation, good ongoing intraoperative and postoperative care, followed by using enhanced recovery techniques. Combining all of these processes, they were able to demonstrate reduced length of stay by almost 40%, better quality of life indexes in patients studied, and reduced postoperative complication rate, especially pneumonia. They also surprisingly had a better metabolic equivalence despite undergoing debilitating treatment. Prehabilitation achieves best results if it is focused onto the appropriate patients. It is most beneficial in patients who have chronic disease, and also onto those patients who need neoadjuvant chemotherapy prior to surgery. What does a program look like? Upon recruitment into a prehabilitation program, the first thing to do is to make a baseline functional assessment using condition-specific healthcare quality of life index mapping, and also the frailty index is also documented. Functional capacity is evaluated using objective tools such as cardiopulmonary exercise testing or 6-minute walk test. In the absence of cardiopulmonary exercise testing, 6-minute walk test is a useful substitute and it's evidence-based. In most of UK, prehabilitation programs are delivered either in the physiotherapy department of the hospital or sometimes in the community gym. We need a flat walking circuit, a muscle trainer for inspiratory muscle trainer, a exercise bike, and resuscitation equipment. Following this baseline assessment, two types of aerobic exercise can be prescribed. One is of a moderate intensity, which needs to be done for at least 5 days a week, or of a high intensity version, which needs to be at least 3 days per week. Alongside, inspiratory muscle training is offered. Some patients, when they are willing, can take up resistance training as well, but there is no substitute for aerobic training. Where cardiopulmonary exercise testing variables are available, these indices can be used to design a well-structured interval training program which is well tolerated by patient and realistic to achieve. As an example, I am showing a slide from a pilot study which demonstrated statistically significant improvement in cardiopulmonary exercise variables following the above mentioned type of interventional interval training. I also would like to present to you a case study which we have come across showing very good beneficial effects. A 60-year-old male patient presented in an acute setting following colonic obstruction due to bowel cancer. Following an anterior resection in an emergency setting, 3 weeks of intensive care was required for this patient to recover. Upon this recovery, he underwent a cardiopulmonary exercise test which showed an anaerobic threshold of 7.8 milliliters per kilogram and a peak oxygen consumption of 14 milliliters per kilogram. This was quite poor by any standards, irrespective of the age of the patient. This patient needed subsequent surgery for resection of liver metastasis, and he was put into a 5-week exercise rehabilitation program, following which the functional fitness improved to an anaerobic threshold of 13.8 milliliters per kilogram body weight, and a peak oxygen consumption went up to 25 milliliters per kilogram body weight. This is an exceptionally high, a very good outcome following this exercise rehabilitation. Following a liver resection, this patient had just a 6-day inpatient stay, followed by a rapid recovery into the community. He suffered no complication and continues to be well. There are a number of challenges in implementing prehabilitation in any setting. What we need is multi-center, pooled data studies along with cost-benefit analysis in order to secure consistent funding for these programs. Patients and clinicians will need to be adequately resourced in order to maintain compliance. Many models of treatment programs will need to be designed for specific patient groups and pathology. The best possible outcome is seen when patients are offered individualized treatment with good monitoring. Inadequate resources will obviously have a detrimental effect and poor outcome. What is the future for rehabilitation programs? In UK, Macmillan Cancer Support have come to the conclusion that there is enough beneficial effect and cost benefit in the long run. To the extent they have now recommended that rehabilitation programs should be offered to all cancer patients immediately after diagnosis and not wait until the treatments are planned. It also recommends that we should not be limiting this option to surgical treatment options only. As a summary to this talk, let me recapture some key points. Physical activity is irrefutably linked with better survival. Rehabilitation programs will need to be designed to local needs and types of cancer and targeted towards high-risk patients. Rehabilitation should run alongside other treatment plans and preoperative evaluation. Motivational and anxiety relief has synergy with physical activity and should be harnessed for optimal impact. Long-term survival and healthcare quality should be our focus along with 30-day survival. Empowering patients to contribute to their well-being improves both short and long-term benefits, and rehabilitation is an excellent tool to achieve this. Thank you very much, and I'm happy to take some questions.